obs and gynae trainee. I'm an obs and gynae trainee in Liverpool, and just generally about GASOC, I'm assuming you guys know a little bit about it, but we're a collection of trainees who just want to promote global surgery, anaesthesia and obstetrics, and we've got lots of different things going on. So we've got a Twitter page, we've got a website and stuff, so please do go and have a look at those bits and bobs if you haven't already. But we rotate through the different specialties, and tonight is an obs and gynae journal club. And we are super lucky to have Mary McCauley and Hannah McCauley with us, who are sisters, and yeah, sound very similar and share the name, but they also work in very similar field of work, and I'm really excited to hear from them and what they've been up to. So Mary, in the way of background, well, you'll be able to share a bit more about what we've been doing, but Mary's an obs and gynae consultant at Liverpool Women's Hospital. And she had undertaken a PhD at the Liverpool School of Tropical Medicine, which is the work that she's going to be sharing a bit more about this evening. And Hannah is a midwife by background and has previously led like standalone midwifery units back in Northern Ireland. She's worked in London, and she's also undertaking her PhD at the moment at the Liverpool School of Tropical Medicine. And Hannah, you've also taken on a new role as well, is that right? I don't know what the official term for it is.
Yeah, I work at the Liverpool School of Tropical Medicine as a senior research associate. I've been there for 4 years. So alongside doing my PhD, I've been doing some research implementation work around competency-based teaching and learning for, especially for midwives, around antenatal, postnatal and emergency obstetric care.
Brill, thank you. So the general format for tonight then, we're going to hear from Mary first and then following on with Hannah. So we're going to have a presentation from Mary. You'll have all been sent the links for the papers, so perhaps you've had a chance to read them, perhaps not, but hopefully you'll get a gist from this anyway of the work that they've been doing. And then there'll be a time for discussion, questions. I just ask that we want healthy discussion, but do be respectful of people as well. We can do that via the chat function. Please feel free to type your questions and we can read them out. Or if, because there's a relatively small number of us at the moment, it might be more appropriate just for us to unmute and just speak. We'll see how it goes. And we aim to be finished definitely by 8 o'clock, possibly a little bit earlier. We'll see how things go. Is that all okay? There will be feedback sent out in an email at the end in the next day or two, and certificates will follow on from that. So please do let us know what you thought. And this is being recorded, so I hope everyone's been okay with that. Again, it was in the email. So yeah, Mary, over to you.
Brilliant. Well, good evening, everyone. Thank you so much to the committee for the opportunity to share some of the work that I've been involved with regards to global maternal health. So the title of this presentation is Global Maternal Multimorbidity, Survive or Thrive. And that really was the question that I aimed to address as I was working as a researcher at the Liverpool School of Tropical Medicine. As Amber mentioned, I'm currently working full-time clinically as a consultant obstetrician at the Liverpool Women's Hospital, with the view to, in the future, continue with international maternal health research. Oh. Okay, so I'm just going to run through how did I get involved in maternal global health research, current global health strategies, the PhD of which the paper is the first paper assessing the burden of maternal multimorbidity, and then really to have a quick discussion or questions about how has this paper or this research impacted current change in low resource settings. And to be honest, a lot of my work, Hannah's paper and the work that she's involved with really leads on to the work that I was involved with at the start. My global health inspiration as a teenager, I read this book, The Hospital by the River, and I was really inspired by the work of Dr. Catherine Hamlin, who unfortunately passed away only last year. She was an Australian obstetrician, and herself and her husband, also an obstetrician, took a sabbatical, and they were posted to Ethiopia, and it was there whenever they were working that they came across ladies who were suffering from obstetric fistula due to obstructed labour, and they really pioneered and really changed healthcare for women in not only in Ethiopia, but then they implemented the fistula repair surgery, and they trained other doctors and surgeons in Africa, and they have really just to see how two people have had a massive impact on perhaps thousands of women's health and well-being in low resource settings. So I read this book and I was like, wow, in the future, I would love to be involved in some type of work related to that. However, I was from Northern Ireland and I did my specialty training in Northern Ireland, and there isn't a lot of opportunity in Northern Ireland for global maternal health. So after my exams, I applied to the Royal College and was kind of trying to get as much information as I could about opportunities to undertake global health research or global health placements. And the college do currently have an accredited relationship with the voluntary services overseas. And I applied and I was posted to a hospital in Ethiopia, and I was absolutely delighted. I was so excited and delighted that there was a hospital. I was given a hospital placement in Ethiopia after especially reading the book by Dr. Catherine Hamlin, and on this site there was actually a fistula hospital, and during my placement I did actually get to meet Dr. Catherine Hamlin, which was really it was a really special time for me. So this is the outside of the hospital where I worked for almost a year, and you can see it's really beautiful outside, but inside is a very different story. And this was a labour ward whenever I arrived, so you can see as the discussions go on, why would we expect women to come and give birth in these facilities? So these are 2 beds, and you'd have 2 women on each of the beds at the same time, with maybe 10 students around, and there was very little privacy and very little there was very little good quality care given, unfortunately. So after doing a clinical placement, I came back to the UK and I really pondered how can I continue to be involved with or to improve maternal health in low resource settings. I really wanted to make an impact. An African proverb that I've heard is, if you want to go fast, go alone. If you want to go far, go together. So I really needed to find my team. I realised there's lots of different teams doing excellent work, even in the UK, with regards to maternal health in global settings. But I really found my team at the Liverpool School of Tropical Medicine, and there was a posting that came through for a clinical research post there. So I applied, moved across from Belfast to Liverpool, and that was 7 years ago. So I never expected to be here for 7 years, but I did the clinical fellowship or the clinical research post, and then that led on to the PhD. So it was through working at the School of Tropical Medicine that I learned that the burden of maternal deaths are in low and middle income countries. So this is the kind of pictorial diagram of the burden of maternal death, where the red is the highest numbers. And in converse, if you look at public health spending, so this shows where most countries spend money, public health spending on the health infrastructure. So you can see the difference. So where there's less public health spending, it's the women that are often can be the most vulnerable at that time. Maternal mortality internationally. So it's kind of, if we think about one airplane crashing every day for a week, that's a kind of equivalent to the numbers of women that are dying due to pregnancy and childbirth complications. But unfortunately, because the women on these planes are from low and middle income countries, it doesn't necessarily make the headlines. And when we think about the current or previous global health strategies, the Millennium Development Goals, which are now way past, but do give context to work that has been developed previously, you can see that there is number 5. There was 2. One was related to improving maternal health, and the other was reducing child mortality. So they were quite pivotal and important strategies at that time. And along with the centre where I was working, over the past 10 years, they had developed interventions with regards to emergency obstetric care to really improve care for women and babies at the time of birth. So to prevent death, really. And for that, whenever I arrived at the department, I was so impressed by the work that the team were doing that I actually nominated them for this award, which was the BMJ Women's Health Team of the Year. And because at that time, the department was working in over 10 low and middle income countries, with the governments, with the ministries of health, training, offering the training package, and then going in and training healthcare providers in emergency obstetric and newborn care, and then training. We do the training of trainers, and they go on to train other healthcare providers, and it kind of a cascade effect. So we won that award for that year back in 2005. But then from 2005, we now are in the era of the Sustainable Development Goals, of which there are 17. And unfortunately, you can see that maternal and newborn health has kind of dropped off the priority list. Number 3 is really the only kind of goal that is related solely to health. And then if we think of the global health agenda, it's kind of moved from preventing death into improving health and well-being. And that's really important. And there has been progress in decreasing maternal mortality across many low and middle income countries, and rightly so. The emphasis now is not only to prevent death, but to improve women's health and well-being. And the kind of key things are that it's not just enough for women to survive pregnancy and childbirth. We need to use that as an opportunity to improve health and well-being for women during and after pregnancy, in order that they survive, they thrive, and that they are able to then transform and contribute to society. So along with the global health maternal strategies, the Centre of Maternal and Newborn Health within the School of Tropical Medicine then branched out, and we started to do a lot of implementation research, looking into how to improve pregnancy care before and after birth for mothers and babies. So maternal ill health, so this was my topic of interest. And if you think of it, really, you can relate maternal ill health to an iceberg. And at the tip of the iceberg, you see those are the women that unfortunately pass away. And they're the numbers that are collected within healthcare facilities. And they're the numbers that are reported within regions and nationally and internationally as the maternal mortality ratio. But beneath that, until recently, there hasn't really been a lot of primary data as to the burden of ill health for women attending healthcare facilities across different low and middle income countries. So kind of related to the iceberg analogy, if we think of maternal death at the top, then beneath that we have a category of women who suffer severe acute maternal morbidity. So that would be, for example, a woman who has eclampsia, but because it's recognised and treated, she doesn't die. Or a woman who has a massive obstetric hemorrhage, but because it's recognised and treated and given blood transfusion, she doesn't die. And then beneath that, we have a category of women who will suffer maternal multimorbidity. So that's kind of different types of ill health at different times of the pregnancy. And until recently, we didn't have a definition, or we didn't have primary data as to the possible burden of what that was. And then beneath that, we will then have a category of women who are, healthy before, during, and after the pregnancy, and don't necessarily require specialist treatment, or they don't really require intervention. So my area of interest really was maternal multimorbidity, and this was the PhD. My PhD was funded through Bill and Melinda Gates via the WHO, because at that time, and back in 2015, this was really one of the priorities. So when we think internationally, maternal deaths, there is a definition for maternal death, and there is a WHO criteria of how to measure that. And that's what we use to compare countries' kind of health status or quality of care for maternal health. And that's the definition at the tip of the iceberg. Beneath that definition, you have severe acute maternal morbidity. And this is a woman who nearly died or survived a complication because it was recognised and she was treated for this. And the WHO have a category of how different countries can measure this. Again, it's a proxy for quality of care. And so they can compare between regions, or can compare between countries for this. And then back in 2013, the WHO used a team of experts to develop a definition for maternal morbidity. So they defined it as any health condition attributed to and/or complicating pregnancy and childbirth that has a negative impact on the woman's health and the woman's well-being and/or functioning. So quite a broad definition. And this was agreed as a working definition. And then my objective, working with the researchers at the School of Tropical Medicine, was to develop a data collection tool and a criteria to then assess that. So that was the aim of my PhD, to measure multi-maternal morbidity. The objective was to develop a data collection tool, to field test the data collection tool in 4 different countries and different types of primary healthcare facilities. So in primary healthcare facilities, and secondary, in different settings, so in rural settings and urban settings. And then to determine the prevalence, the types and factors associated with maternal morbidity at 5 different assessment points of the pregnancy. So early pregnancy, late pregnancy, just after birth, and then within 1 week of birth, and then within 1 to 6 weeks of birth, postnatal care. So we collected data in Malawi, in Kenya, Pakistan, and India. So we collected data. It was a cross-sectional maternal health survey and we collected data on over 11,000 women. So whenever it came to analysing the data, it did come across that there was quite distinct types of morbidity that we could categorise as physical, and that could be split quite into infectious or medical and obstetric, and then psychological morbidity, so symptoms of depression or thoughts of self-harm, and social morbidity, so domestic violence from the partner, husband and or family members, depending on the living circumstances within the culture, and then substance misuse. So the paper is there. I'm not sure whether many of you have a chance to read it. There's a lot of data. So I'm just going to give a summary of the data. So when we asked women, how satisfied are you with your health? Their immediate response was 3 out of 4 women reported that they were satisfied. When we asked about quality of life, 3 out of 4 women reported good quality of life. However, when we took the time to go through a comprehensive assessment, screening women for different types of physical symptoms and severity, 3 out of 4 women did report at least one moderate to severe physical symptom. And then when we took the time to offer a top-to-toe examination by a trained healthcare provider, so that was a midwife or a junior doctor, 3 out of 4 women had an abnormality when examined by a trained healthcare provider. When we offered women free point of care testing in these settings, 3 out of 4 women had an abnormality on the investigation. So that would be including blood samples, screening for HIV, syphilis, malaria, and screening for urinary tract infections. Of the investigations, 1 out of 2 women were anemic. 1 out of 4 women had early signs of infection. 1 out of 4 women reported psychological ill health. And 1 out of 3 women reported social ill health. So the summary here is all the women grouped together as one cohort, but there was different trends across different countries for different types of physical, psychological, and social ill health. So I kind of thought maybe all these women, maybe there's a group of women who attend a healthcare facility and they have all of the ill health, and if only we can identify them and then treat them and then provide care for them, then that would kind of solve everything. But whenever I went through and looked at the different types of ill health that women are reporting or that we found on detection, actually there was around 2,000 women who'd had no morbidity. So that's the woman at the bottom of the iceberg or the triangle. But over 8,000 women did have at least one type of morbidity. You can see the numbers here. Lots of different women actually have different types of morbidity that overlapped at different stages. And out of 11,000 women, there was only around 136 that had all 4 types of ill health. So there's not, unfortunately, a group of women that if we could identify and provide best care for, that it's going to solve everything. So it really shows that different people have different health needs, and we need to assess every woman for all types of health, ill health during and after pregnancy in order to provide best care for them. So the work has been published. We'll have a chapter in one of the global health textbooks, and then the paper that we can discuss further during the discussion point. So the burden of physical, psychological and social ill health during and after pregnancy for women in India, Pakistan, Malawi and Kenya. So that's been published in the BMJ Global Health. And then the other papers from the PhD. So I not only looked at the burden of disease or ill health, but I also looked at different assessment points. So where, at what time of the pregnancy do women report different types of psychological, social and ill health? And that again has been submitted and under review with the BMJ Global Health. And to be honest, it's kind of things you would expect. So infectious morbidity is highest early postnatal. Hypertension, preeclampsia and incontinence are actually most common in the second half of pregnancy, antepartum hemorrhage common in the first half, anemia in the early postnatal. But of note, psychological and social comorbidities were significant at every stage and were actually more highest in the second half of the pregnancy. So I know we talk a lot about postnatal depression or psychological support that women need after birth, but our findings are that actually women needed more support during the pregnancy also. Factors associated, we looked at factors and interactions between different types of ill health. The key findings are actually there isn't a group of women again, so it's not the women who are very young or the women who are very old. It's not the women who are very poor necessarily. It's not all the women who have different levels of education or have had previous poor outcomes. There were associations between these factors, but there wasn't any consistent direction between the different countries or as a cohort. So the direction of association was different in different countries, and there wasn't, again, it comes back to the fact that there isn't a group of women with multiple risk factors that if we identify and screen for them, that we will solve everything. All women need to be assessed, no matter what their age or their background or other risk factors. So some other work that I kind of did alongside the PhD, well, I really wanted to find out, so what are women's views? What do women in low resource settings understand by health and well-being as we are trying to plan interventions to address and improve their health? So a lot of ill health actually was highest in India and Pakistan. And so one of my master's students, she went out and she interviewed people to ask them, what do you understand by ill health? And it was a qualitative study, and we interviewed over 130 women attending for routine antenatal and postnatal care. And women understand that health isn't just physical symptoms. They are aware that psychological and social aspects of health have an impact on their pregnancy and have an impact on their health and well-being overall. One of the key things that we did as part of the PhD was to ask women about their social morbidity. And they, when asked in a sensitive way, women did disclose different types of domestic violence. And that was really high in Pakistan. So again, another master's student that I worked with, she went to Pakistan and she interviewed healthcare providers as to what their views are about trying to address this when women attend for routine antenatal postnatal care. And she interviewed 25 doctors and also some public health doctors and also health managers. And many of the doctors reported that, yes, they understand, they know that domestic violence is a problem. They know that they should screen for it, but they don't have the capacity to screen for it. And the kind of cultural understanding was it's a family matter, it's a social matter, it's not the matter of a healthcare provider to approach that subject with women as they attend for antenatal care. One of the other key things we did during the data collection was to screen women for maternal mental health using the Edinburgh Postnatal Depression Score. And again, when we take the time to assess women and ask women the questions, many women do report symptoms suggestive of depression and or thoughts of self-harm. And therefore, another master's student, she went off to Ghana and she interviewed healthcare providers about their views for screening maternal mental health during and after pregnancy. And again, same themes. Many healthcare providers know it's a problem. Many healthcare providers appreciate that it will have an impact on the woman's health and well-being, but it's not there. They don't have capacity. They've got other priorities. The physical health of the woman is their priority. And then some reported that, well, if we screen for it, what can we do about it? There's no medication, or there isn't the health infrastructure to then provide best care for women if they disclose depression or thoughts of self-harm. So the paper really was it was a pretty breakthrough paper because it was the first time that we were able to provide primary data for maternal multimorbidity. Prior to the kind of this approach, there's lots of research and reports and data for women with preeclampsia or women with PPH or women with depression or women with malaria, but there hasn't really been a cohort of women who assessing all different types of health needs during and after pregnancy. And along with the kind of way that we designed things previously with emergency and obstetric care, we kind of looked at where is the burden of disease, and then we implemented and designed as a team antenatal and postnatal care packages, and we developed a manual for healthcare providers, a manual for facilitators, and Hannah, I think, will talk a little bit about how that has been implemented across 5 different countries I forget which ones they are at the minute, but this has been adopted by different ministries of health to then upskill and to train healthcare providers on how to assess for not only physical, but psychological and social morbidity for women who attend for care during and after pregnancy. So I suppose my summary is that it's not just enough for women to survive pregnancy and childbirth. I think that when women attend for healthcare facility in any country, that is a window of opportunity as healthcare providers to provide best care, not just physical, but also to be empathetic, to provide and to be able to link women to psychological support and our social services for social comorbidities. Brilliant. So I'm going to stop there, and I'm very happy to take any questions or comments that you have with regards to the presentation, with regards to some of the work I've done, or in specific, any questions about the paper that we have tonight.
Great, thanks, Mary. So yeah, guys, please, you can turn your cameras on, please. We're a relatively small group, so I think it'll work fine just to unmute yourselves if you're happy enough to do that. And share your thoughts, bring any questions to Mary. Your work's been very extensive. I mean, even thinking of the sheer numbers that you managed to capture, logistically, I feel like that would be a nightmare to get together. Well done. And across like sort of 2 continents as well, to really, yeah, capture some of that data is so important. Do we have any burning questions from anyone in the audience?
Yeah, Joe, I was just wondering, I think that's a really interesting point of what you were saying. I think you mentioned in Pakistan that the healthcare providers said, well, what's the point in screening for them if we can't do anything about it? What do you think is the next step really for that kind of multi-morbidity to be prioritised? Because like you said, we're really good at talking about PPHs and even fistula these days. How do we move forward and start talking about morbidity? Obviously, data collection and proving the point is a really good start, but have you got any ideas for moving forward?
Yeah, so the WHO antenatal and postnatal guidelines are actually that it has to be context specific. So they have considered this because, you know, there is the debate, is it ethical to ask and screen for ill health if you don't have the ability to then provide best care or to treat the woman for any ill health that they do report? So kind of for psychological morbidity and social morbidity, we have, that has been the ethical discussion throughout this whole project and continuing. So the WHO's answer is it's cultural specific, but I suppose the work that we've done shows that if you take the time to train healthcare providers to have the confidence to approach this, then women do interact. Most women will interact, and they will respond to questions. And I think it's just, I personally think it is a massive burden of disease, and we can't just ignore it because we don't necessarily have the best care to provide at that time. But sometimes even I'm an advocate for screening because I think that if we can screen, then, you know, it gives more strength to then persuade governments or to persuade the healthcare managers and the ministries of health to then provide care for women, to have link resources, to have a referral system in place. And often it's not massively severe psychological or social morbidity, but even to talk about it, I think, can sometimes relieve women's anxieties or difficulties, to show empathy, to have some basic counselling. You know, all healthcare providers, as we have done with the new interventions, to show that healthcare providers do appreciate basic refreshing course and skill course in role play and counselling of how to approach these type of sensitive subjects, and to provide some basic care. So I think we have to continue to push for this to be part of the global maternal health agenda in low resource countries.
Thank you.
You're welcome.
John?
Thanks, that was a great talk. Sort of on a similar theme, what are your feelings about the reliability of data that's collected by governments by the systems in the countries you were working in? And then sort of going forward with thinking about new research, what do you think is a good way of collecting data about these kind of issues?
So a lot of whenever I started working in research, then I started to, read lots of reports about estimates of maternal death, estimates of maternal more severe acute maternal morbidity, and started to realize that actually some of the data that is reported is actually based on modeling of either previous data. It's not necessarily up to date. It's not current data. And even from personal experience of working clinically in Ethiopia, I realized that the register, some babies who died weren't registered because then it meant that they had to charge the lady for coming to the facility to give birth. So I can see that, of course, there are complications with data that we have, and we always have to question the data. It could be a little bit, even the data could be worse. I doubt it's, or it could be, I doubt it's going to be better, because, you know, I appreciate that different healthcare facilities in different regions don't want to have poor healthcare indicators. So how to work best? So I think partnership and collaboration is the best thing, to work with research institutes who do have all of the standard operating procedures for audit on how to collect data, how to clean data, how to present data. So I think it has to be a collaboration between and sharing of resources, sharing of information. I think that's the kind of the best way to continue to improve data collection.
So tech isn't a magic answer then, sadly.
Tech, well, to be honest, the PhD that I did prior to this project in the department, it was all paperwork. So you would have people would go out, trained healthcare providers would go out and they'd have a paper questionnaire they'd fill in. And then that would be sent back via like a fax machine to the department, and somebody was employed to go through and then to read that and put it into an Excel spreadsheet file. So that was the kind of how cumbersome the data collection was before 2015. So with my project, for the first time, we used electronic data collection using iPads, and remarkably, we were able to, healthcare providers were able to fill it in online and then send it via a text message to the UK, and then we would be able to download the data and import the data. So actually electronic data collection has revolutionized data collection. But again, you know, the data, whatever data you put in is only, it's really important what data you collect to therefore be able to make sense of the data. So, you know, data designing data collection tools, and, you know, really thinking about what data do we need to understand here is important. But yet electronic data collection is and has improved definitely the availability of data across many different settings.
Thanks ever so much.
You're so welcome.
Mary, can I ask a question? In terms, hello.
Hi.
In terms of, I guess, feedback and like, so the handbooks and stuff, is that done? I was just thinking about how receptive some governments would be to some of the work that you're doing. So does that go back at a strategic national level, or is that more just in cooperation with like other organizations? Because I'm just wondering how receptive certain governments would be to some of the stuff that you're finding out, and whether, how, I suppose because I live in England, I just assume that, you know, it's a top-down filter model, but how, if there's a question that how that's being received, is that something that is a possibility?
Yeah, so the department where I was working, all of the research priorities were aligned with the, you know, the global maternal strategies and the WHO strategies, and we were a WHO collaborating centre for a long time. So, you know, there isn't much, I'm not a believer to doing research just for the sake of it. I want to do research that Amber was chit-chatting at the start of the meeting that she loves maternal global health, and I love it, you know, but she doesn't want to do the research, but I'm kind of realized you have to provide the data in order to be able to inform discussion and to continue to advocate for different agendas to be, you know, for things to be prioritized, because you're able to provide that data. So receptiveness, it's all about, you know, we've developed a package along with the international recommendations or international guidelines, or, you know, the international now burden of disease that we know. So we offer, you know, often we offer the package to governments, or we offer the package to the ministries of health. So often we don't work unless we're invited into the setting, and we offer them, we kind of share with them what the interventions we have available, what manuals we have available, what training packages we have available. And to be honest, some we have, you know, stakeholder meetings at the start before any intervention starts, and some governments and Ministry of Health do ask us not to concentrate on different types of the training, so that it is acceptable to their healthcare providers and the healthcare system. But we do advocate that we know that this is a problem, and that we would prefer to prevent, you know, to provide the full comprehensive package and training available. And Hannah, I think Hannah then has implemented this care package in different countries, so she'll be able to comment on the receptiveness. also, but overall most governments are. Most people know these, like as we've shown with the research, people know this is a problem, people know it needs to be addressed. It's just a matter of how, when and where, and how to prioritize the resources. So that's why it's important to keep having these meetings and keep sharing and sharing with our networks also. Yeah, nice.
Great. Thanks for your question. Ewan, you've had your hand up for a little while, and then we'll come on to Kathy.
Oh, yeah, I know I said I'm doing not obstetrics at the moment, but I previously have worked in Africa doing obstetrics for quite a while, and I think what your data, which is really impressive number, is just showing how complex all the problem is. It's just enormously complex, and the deeper you go into it, the more difficult it gets. So I was really interested to see that the new version of the Millennium Development Goals don't really include maternal outcomes anymore.
Yeah.
I was really interested to know whether you think that there is an avenue for, now that something's not in a target or because my experience was that the targets were often faked and it was almost unhelpful to have that millennium goal there, because they knew that they had to get their their perinatal mortality had to be below a certain amount. So it was below that amount, if that makes sense, where I was working, which definitely led to more reporting bias. So I was wondering if you had an idea about how maybe, obviously the target was good because it did, it's done great things, but is there a way we can improve it, have a more complicated or a more real world way of assessing how a place performs?
Yeah, so I suppose along with the Sustainable Development Goals, kind of priorities are really expanded, and it's all really about peace, prosperity. There's the 5 Ps, I forget what they all are, but it's all about peace, prosperity, people. And so good health, so number 3 is good health for all people at all stages. And actually within that, there are different sub-targets. And one of those sub-targets is to continue to decrease the maternal mortality ratio. So maternal mortality is still within that. And then across maybe some of there's gender equality, and that kind of will bring in a little bit of the domestic violence and social morbidity under that target. So within the Sustainable Development Goals, there are some kind of targets that do interlink across with health and well-being, to continue to aim to have these targets. But as you say, it's very difficult, and maternal and newborn health has kind of dropped off the agenda, I would say, a little bit. And we have to continue to advocate for it, and to have to continue to say that still things have definitely improved over the past 10, 15 years, 20 years, but there's still a huge burden of disease or ill health that we can address and provide care for to improve health and well-being. Yeah.
Thank you.
Thanks, Mary. Kathy, did you have a question? If you unmute yourself.
Oh, hi. Sorry. Can you hear me all right?
Yeah.
Yeah. Oh, thank you, Mary. That was a really good talk. I heard you do a talk at LSTM for the DTMH. It was brilliant. Thank you.
You're so welcome.
I really think that this is fantastic, and just looking at the global burden of disease from maternal health, but gynecological disease as well, should really way up there on the priorities of the World Health Organization and the Millennium Development Goals. But I just wanted to ask, what's next? What did he think of your research? Were they shocked? Have they come back and said, you said it's going to continue to be part of their sort of World Health Programme, but have they sort of come back and said, actually, we need to think about this more? Because Ewan asked the question that I was going to ask about sort of reporting bias and really sort of trying to make sure governments take on board the points that you mentioned. But for example, it's not long ago, is it sort of 5 years ago, that Malawi only had 1 psychiatrist in the whole country. So, taking on board the fact that women need more mental health support in the postnatal period is really important.
Yeah.
So I just wondered what whose response was to your work being a WHO affiliated centre.
Yeah.
Are they gonna really maximise women's health really on the agenda to the point of malaria, TB, and other global health priorities? I think, you know, it's a big question, but I just wondered what your kind of reception was from their side.
So yeah, the WHO. So if you think about that iceberg, the WHO, their responsibility is really to kind of provide guidelines and recommendations. So they have developed the WHO. They had a maternal morbidity working group, of which one of my professor was one of the team, and they developed the definition, and then we've developed the data collection tool. We've developed the data, so the data has now been published, and different groups have actually then used the data collection, or a version of the data collection tool, to actually collect data in different settings, so we can now begin to compare and contrast. So the WHO, you know, I think it's brilliant that they've prioritized this, but it's up to the implementers to then implement their recommendations. And that's why I just love the School of Tropical Medicine so much, because they're implementers. We did a lot of implementation and still do implementation research. So we take the guidelines, we develop the package of care, we implement the care, and then we evaluate the effectiveness of the care. And I think that's one of the ways to change. And then it all comes down to, how do you evaluate, and what data do you collect to show that it is having an impact, if anything. That's the work that Hannah's been involved with. About implementing these new antenatal postnatal care for midwives and nurses and doctors in service, and then evaluate how effective it is. And the feedback's been fantastic. The feedback's been, healthcare providers are like, this is brilliant. Of course, we want to spend more time with women. Of course, we need room resources. And that's how things change. And we have to continue to, I think, provide the data to advocate on behalf of women, and to continue to lobby the healthcare ministers and the systems to provide resources, provide more healthcare providers, to overall continue to keep women as a focus for their health and well-being.
Brill, thanks, Mary. Do we have any other questions for Mary at the moment that anyone wishes to ask? Or comments? Said? Go on, John.
Well, sorry for asking such an overly simplistic question, but I mean, Mary, what do you sense is the lowest hanging fruit at the moment then, that we can really kind of lead to the biggest impact? What changes can be done that's relatively easy?
I think what we're doing, which is training healthcare providers to provide comprehensive care for women, not to ignore psychological and social ill health. You know, we do it in the antenatal clinic. You know, I do it at every contact. You know, now that we're with COVID and everything, at every contact we're asking women about, have they had their COVID vaccine. It's just that kind of thinking for healthcare providers at every contact. How's your physical health? How's your mental health? Are you in a safe relationship? Can we support you in any way in these type of areas? I think that kind of will then be able to change things over time, definitely.
And do I get the sense from you that perhaps what you're saying is that maybe good antenatal care is almost more important than intrapartum care? Or are we not quite at that stage yet, do you think?
No, I don't think one's more important than the other. Intrapartum is where you've got the highest risk of mortality, because, you know, that's the highest risk time, and we have to get that right. And kind of my thoughts are, we're beginning to get that right. More women are surviving complications during the time of birth and childbirth. But I kind of also think that, like, if you've worked in different healthcare facilities, some women attend the facility for antenatal care. Like, they want to come to the facility for antenatal care. It's a big thing. They want, you know, some ladies, they get dressed up, and it's a social event to go to the hospital for antenatal care. But whenever they arrive, there's long queues for them. You know, there's long queues. They're not getting best care possible. So I think all aspects of care have to be given. It has to start right back from the booking, even preconception, all the way through. You know, we have to provide good preconception care, good antenatal care, good intrapartum care, good postnatal care, and beyond, even if you do have long-term disability afterwards as well. So I think we have to have comprehensive holistic care at all stages of pregnancy.
So I suppose we've just got to lobby for investment in these services, you know, and get governments to cough up, not only on, I mean, it's just so complex, isn't it? Road building, you know, it's challenging in the rural areas particularly, isn't it?
Yeah, no, it's complex, and there isn't, you know, and different settings have different women maybe have different health needs in different settings depending on their backgrounds and things, but overall it is complex, and that's the aim, to provide comprehensive holistic care for all women at all stages of pregnancy. And it will change, we will get there in time, definitely. Just a matter of time.
Brilliant, thank you. That was quite a good sum up in anyway. I'm just conscious of time, that perhaps we should move on, which actually dovetails really nicely the work that, as Mary's already alluded, that Hannah's been working on with sort of implementation side of things. So yeah, Hannah, over to you, my love. And then again, we'll have questions and stuff at the end.
Great, thanks, Amber. Let me just get myself up here. Great, so yeah, my name's Hannah McCauley. I am a midwife and nurse by background, and I've been working in the NHS for a long time. I also worked with voluntary services overseas in Uganda for 2.5 years. And then 4 years ago, I moved to Liverpool, and I'm now working at the Liverpool School of Tropical Medicine. I work there as a senior research associate, and I am also undertaking a PhD. So some of the research that I'll talk about is around my PhD. But what I do want to share today is the systematic review that was undertaken by Lythgoe, who's a junior doctor. And she undertook this in 2019. I was her master's supervisor in international public health. And this is a systematic review that she undertook. So I'll talk you through that. That's the paper that was sent out. So I'll give you a research overview of the systematic review, some of the results and recommendations. But before that, Mary has already talked about the work that I'm involved with. So I was the technical lead on a workshop, a three or 5 day workshop, depending on the setting that the government wanted us to deliver in. And it was a competency-based workshop that was a mixture of lectures, active learning, hands-on demonstration of skills, scenarios. We used a lot of mannequins, high density teaching equipment, and also there was mentoring, self-evaluation and assessment during the program. So it was always at the facility level. We didn't bring people from the facility to hotels. Everything was delivered in the facility to encourage that multidisciplinary team working. And it covered essential components of care, such as screening, preventative care for mother and baby. And also we looked at integration of HIV, TB and malaria services routinely into antenatal and postnatal care. And that was really to recognise that antenatal and postnatal care is an opportunistic way for women who often it's their first contact with the healthcare provider. Let's see if we can then screen, manage these diseases that are often endemic in some countries across sub-Saharan Africa or Southeast Asia. We did have a specific focus on respect for maternity care, communication with women, emotional, mental health assessment and social welfare and care during antenatal and postnatal care. And these are the manuals that we developed, one for the facilitators and one as a take-home manual for every single healthcare provider who came along for the training. Here are the settings that we undertook and some of the models that we used. It was delivered and is continuing to be rolled out in Togo, Nigeria, Ghana, Tanzania, and Chad. So you can see up to date some of the numbers of healthcare providers trained. That was a pre-COVID. Since COVID has hit, we have continued to deliver the training, but we're using in-country facilitators and colleagues that we have trained in country who are continuing to roll out. So I think the number of healthcare providers that have been trained to date is now nearing the 3,000 mark. Mainly midwives that we have trained, and the research that's going alongside this. So there's no point in delivering training unless we're evaluating it. So some of the evaluation measures are, do skills and knowledge increase after the training, immediately after. Also, we want to do longitudinal studies to see whether it changes behaviour in the healthcare facilities as well. And that's some of the research that I'm doing for my PhD. Alongside that, something that really became apparent, and John, you mentioned about the, you know, the low-lying fruit, it was the respectful maternity care aspect of the training that the healthcare providers felt that they could immediately begin to change. So it doesn't cost anything. It's mostly about attitude. It's mostly about knowledge and communication as well, because if we get women to come to the healthcare facility, but they don't get good quality care, they're not seen by a highly skilled healthcare professional who's providing them with good quality care, they will not come back again for other care. They may come for the first antenatal visit, but that will change as they come for second, third, and fourth visits. So that's a little bit of background about the implementation work and research that Mary was talking about. As I said, every year in LSTM, we are given master's students. So we give a variety of topics that we're interested in as researchers, and then the students do research into that. So specifically with regards to respectful maternity care, I was keen to see what is respectful maternity care, and what are women saying, and what are they experiencing as the type of care that they receive from healthcare providers. And so Keaton and I got together and we developed then this research idea. So the background based also on what Mary was talking about. So nearly 300,000 women die each year, and that's the equivalent to one plane crashing every day in pregnancy and childbirth. But over half of these deaths occur during the postnatal period. And there are 2.5 million infant deaths every year, unfortunately. So we can see that the postnatal period is an area where there is a lot of input needed. Pregnant women represent the highest number of users at healthcare facility level globally, with over 80% of women attending antenatal care at least once, and 56% attending 4 times or more. So the current WHO recommendations for antenatal care is that women should be seen 8 times during their pregnancy. For postnatal care, that's 3 times at different time periods throughout the postnatal care period. But we can see there's quite a significant drop off from the first time women come to get care, and it's just above half of all women who receive 4 antenatal care visits. And again, the postnatal care is the lowest continuum of care that women receive, with less of half of all women receiving a postnatal care visit within 2 days of childbirth. So even though that's where the highest morbidity of mortality is, women are not receiving the care that they need to avert and prevent the morbidity and mortality associated with pregnancy and childbirth. So as I mentioned about respectful maternity care, so in response to the disrespect and abuse that women receive during childbirth, the White Ribbon Alliance developed alongside other organisations the Respectful Maternity Care Charter in 2018, and it showed that there was a lack of data around disrespect and abuse and respectful maternity care, specifically after childbirth, but it's widely recognised that the lack of respectful maternity care negatively influences women's perception of care and is recognised as a deterrent to utilisation. So one of the recognised reasons why women are not coming back in the postnatal period is because they haven't received either the quality of care that they wanted, or actually the care may have been delivered in a quality way, but the way that it was delivered by the healthcare providers was not something that the women wanted. So it's really important that we think about, what do women want? We often think about the care that we give. It's a lot of checklists, isn't it? We've got so much to do during our appointments, whether it's antenatal, intrapartum, or postnatal. But what women were saying was, it's how that care is delivered that's really important. And that's what I'm going to focus on. So this is the Respectful Maternity Care Charter. In 2018, it was developed. And I've changed it a little bit. You'll be able to find it online, but I just wanted to show you the category of disrespect and abuse specifically, and then the corresponding human right that aligns itself to. So physical abuse is a category of disrespect and abuse within the Maternity Care Charter, and the corresponding right is women should be free from harm and ill treatment. Again, non-consented care is care that women should not be receiving, and the corresponding right, you can see that, is right to information, informed consent and refusal, and respect for choices and preference. Now, this is for all women globally, so we can think about it with regards to our setting and where we work, each one of us as clinicians as well. And we can see that in all settings, it is sometimes challenging for us to provide these basic rights for women, depending on setting and circumstances. Again, non-confidential care, so confidentiality and privacy. The setting is so important. Is it behind closed doors? Can we maintain that confidentiality? Non-dignified care. We need to provide women with dignity and respect. Again, discrimination based on specific attributes. And that's looking at the care we give should be equitable. There should be freedom from discrimination, and no matter about the woman, anything about her personal attributes, who she is, where she comes from. Again, abandonment or denial of care is well documented, and that corresponding right there is right to timely health care and the highest attainable level of health. And detention in facilities is unfortunately something that does occur, and the corresponding right there that's being abused is women's right to liberty, autonomy, self-determination, and freedom from coercion. So the aim and the search strategy for the systematic review that we undertook was we wanted to see what available qualitative evidence. So we didn't look at quantitative evidence, we specifically looked at qualitative evidence of how the quality of care, and we expanded that to be either respectful or disrespectful in context for this systematic review, how that quality of care influenced perceptions and experiences of, and also decisions to access postnatal care for women living in sub-Saharan Africa. So we wanted to know, was the women's experience of care, did that impact the fact that they came back for postnatal care? And that's what we wanted to look at. For our search strategy, then these are the databases that we, that Caitlin, let's be clear, she did a lot of the searching that she undertook, and she looked through all of the search databases, and we had our inclusion and exclusion to develop our selection criteria. So we looked at qualitative literature in English only that described women's perceptions and experiences of the quality of care received after childbirth, and how this influenced their perceptions of and decisions to access postnatal care. So our mesh terms were words such as respectful care, disrespectful care, abuse, good quality care. So we developed our mesh terms, our inclusion and exclusion criteria. Then we did the screening titles and abstracts of all of the papers that were captured during our screening process. We then sat down together and we did full data text extraction by developing a data extraction table, and we also quality assessed the papers to ensure that they were of good quality, and we excluded papers if they were not of good quality, and I'll show you that in the Prisma diagram. And then the data analysis was based on thematic analysis to extract sub-themes and themes from the papers that then were included in the systematic review. So here you can see the Prisma diagram. Altogether, we started with nearly 6,000, over 7,000. Caitlin had quite a meltdown at that stage, because like, how are we going to go through all of these papers? But by going through and screening everything, then we managed to get it down to full text articles that we thought were eligible, 129. So from 5,800. So once you begin to go through titles, you may say that it's a case study, or actually it's not fully focusing on qualitative methods. So she managed to get it down to 129. And you can see here that after reviewing the full text articles, then we were left with 15 papers that we included in the qualitative synthesis. We can see here some of the reasons. So some of the papers weren't actually about respectful maternity care, or did not document abuse or disrespectful care. Some of the papers were not specifically about postnatal care, and some were not qualitative in their methodology. So this is our systematic way of getting our papers. We then reviewed 15 studies, which included data from 985 women who were interviewed face-to-face across 8 countries in sub-Saharan Africa. The reason we limited our geographical scope was because there was a lot more globally, a lot more across other developing nations. So we decided to look at just sub-Saharan Africa only. And the studies that came out were in 8 countries: Uganda, Zambia, Tanzania, Malawi, Kenya, Zimbabwe, and Ethiopia. All qualitative methods of data collection, so some semi-structured interviews, key informant interviews, and focus group discussions that took place in a number of settings. Some were in women's homes, some were in community centres, and some were in healthcare facilities. So that was really nice because we were able to get a broad scope of settings. If women are interviewed in healthcare facilities, there is a bias there often in some of the responses. So it was really good for us to be able to get that good geographical scope with regards to where the research was undertaken. And then for the results, there were 10 sub-themes identified, 5 specifically related to respectful care, and 5 related to disrespectful care. In the paper, you can look at them all. I'm just going to focus on the 5 that are related to disrespectful care, because I feel this is the part where we can really impact. If we can shed light on what women are saying is disrespectful care, we can then put solutions in place to change that care that they're receiving. So the first one here that we have is respectful care is associated with positive postnatal care experience. So a woman said, I just feel that we need support from them. If the midwife is supportive, then that's all I need her to have. So forget about clinical care. This woman really felt that if she had a midwife who was supportive, that was what was important to her. Another woman said that they wanted to have an audience with the district nursing officer to tell her that she should recruit people who have the love to serve everyone with respect. So again, this woman was saying that that respect is important. For the midwife to be someone who wanted to care for women was the most important thing for that specific woman whenever she attended for postnatal care specifically. Another sub-theme was that women wanted informed care from healthcare providers. And someone said, honestly, I benefited a lot from postnatal care. Apart from the treatment, they also teach us many other things, such as the proper way of handling a baby when breastfeeding. So this is talking about health promotion and opportunistic ways to support women whenever they're caring for their babies. And also the nurses emphasized to us that this time, it is your responsibility. You can choose for yourself the feeding method you want to raise your baby with. So again, giving women information, empowering them, letting them know that it's decisions that they can make, and empowering them to make those decisions. Another sub-theme then related to disrespectful care and abuse was stigma and discrimination. So unfortunately, there was times where verbal abuse was happening at the public hospital. They were shouting, they say, you foreigner coming in to make a baby here. So this person was discriminated against by not being from that area. Sometimes when you get to the facility and they look at your documents and they realize you're infected with HIV, they do not handle you the same as the one who is not infected. So again, women receiving different type of care, not getting quality of care because they have HIV. And this is a quote that's related to someone's age. They are just talking, saying, I am so uncooperative, and yet I am so young. And why am I doing all these things if I am not going to face up to it? So this young person felt that because they were young, they were being discriminated against on that specific personal attribute. And also denial of care. So some women said, actually, whenever they went to the healthcare facility, they weren't given the care that they needed. This woman reported that after delivering, I spent 1 week when I had no problem. Even the baby was suckling and sleeping well. After 3 days, she got a fever and she was really badly off. I said, let me take her to the facility. Maybe I would be helped. And they told me the medicine is not here for me because I delivered at home. So this woman, after giving birth at home, went to the healthcare facility to seek care, and unfortunately was denied that care that she needed for her baby. And another woman said, if you've delivered safely, you can't stay. The only time you can, they say you stay for 24 hours if you have problems. We know the rules. So she's saying she actually couldn't stay in the healthcare facility, even if she wanted to, if she felt she needed to, they actually were not allowed to stay there. They had to leave. And again, this is denial of care based on where you give birth to your child. If you go to the clinic after giving birth at home, nurses make you pay before they examine your baby. So denial of care based on not being able to pay or where you have given birth. And the last one then I'm going to look at is non-dignified and disrespectful care. So when we go late to the clinic for postnatal care, the healthcare providers complain that they are getting a meager salary and yet we keep bothering them. So if a woman is late attending, the attitude of the healthcare providers is negative. And other women reported that we did not go to the hospital for postnatal care because if they noticed that you delivered from the village, she, the nurse, can easily beat you. So it is better I go to the old lady in the village because I know she will treat me well. So this is someone reporting that going to a traditional birth attendant, delivering at home with a traditional birth attendant was better for her because she knew she would be treated well. She was not really that bothered about the impact that we know about morbidity and mortality associated with that. And again, I think this sums up great. It's about attitude. The way sometimes patients get treated, it's not okay for me. Sometimes you find that people are afraid to ask certain things because you find that health workers can't be approached. It's not okay the way they deal with patients. I am not happy. So these are some of the quotes that came through from the synthesis whenever we did the thematic analysis on the systematic review. We can see that overall descriptions of disrespectful care far outweighed those of respectful care. The high-risk groups for stigma included adolescents, women from poor socioeconomic backgrounds, women who were HIV positive, and women who had non-facility births, so did not birth in the healthcare facility. They were more likely to have disrespectful care. Women's experience of discrimination negatively influenced their perception of postnatal care and discouraged utilisation. So that showed through the papers that if they were discriminated against, they would not go back to seek care again. And also power imbalances between women and healthcare providers underpin the disrespect and abuse that women experiences. And that again is linked in with poor socioeconomic status, adolescence. So those power imbalances really do impact upon the care that women received, unfortunately. However, descriptions of respectful care included healthcare providers being kind, supportive, and attentive to women's needs. Women described preferring healthcare services where the providers communicated in a respectful and caring manner. And again, descriptions of disrespectful care included verbal and physical abuse and power imbalances between women and healthcare providers. I've just done another bit of research, and it's still prevalent that verbal and physical abuse is something that is happening. I think that we may have seen in our own settings or have been conversant with some of the things that I've discussed here, but verbal physical abuse is something that is still prevalent in settings in low and middle income countries. And again, it was evident that where you give birth did impact upon the quality of care that you were given with regards to respectful or disrespectful maternity care. So in conclusion then, okay, it's a so what question. So what, okay, we know these things. I think first of all, it's really important to recognize that some of these settings is extremely difficult place to work. Low salary, not getting your salary on time, a high volume of women attending for care. Often there may only be one healthcare provider as well. So it's important to recognize that these are difficult situations to be working in. And it's not that midwives or doctors want to provide poor care, but there's so many associated factors that I think it's important just to mention that. It's multifactorial, and we need to think about solutions that will be multifactorial. So evidence regarding why women do not routinely access postnatal care are limited. So there is a need for a new approach and focus. Why are women not coming for care? What can we do to improve that? We think that comprehensive and routine audits of respectful care during postnatal care is necessary to inform policy and programme decisions and for resource allocations. So as well as respect for maternity care and attitudes, we know that, the enabling environment in the healthcare facility does need support, equipment. Do they have the right equipment as well? And I think this is not just in sub-Saharan Africa, but across all care. We need to provide care that meets women's expectations and health needs. And that's different in every setting. It's different across countries. And we need to make sure that all of our interventions, all of our research are setting specific, and that we always include women in our research, that we continue to ask them what they need and what they want. And some of the research that's coming out from what I'm doing is that the midwives really, really welcome the respect for maternity care and the social screening and psychosocial screening, because this was something they could do without waiting for a policy change, without waiting for equipment to come through. And that can really change the relationship and the contact that women have with the healthcare providers. Just briefly, I'll just mention on research we did alongside this in Togo. So I undertook some quantitative research. I used a validated tool that a medical doctor called Dr. Shifru in Ethiopia had undertaken, and it looks at 4 aspects of respectful maternity care. So friendly care, abuse-free care, timely care, and discrimination care. So this was undertaken last September. Togo is a French-speaking country, so we delivered the data collection in French. We interviewed 330 women, 185 were in the antenatal period, and 145 were attending for postnatal care. Just to give you an idea of what care is being undertaken there with respectful to that. So most women felt that the care they received was respectful maternity care. And the highest scoring response was that they felt the healthcare providers were caring, friendly, and treated them with respect. And most women felt that the healthcare providers treated them with concern and empathy. And more than 60% of women felt that their needs were met during the contact and that the care they received was culturally appropriate. However, timely care was the component that scored the lowest. And that just, the women had to wait for longer. And that was to do with lack of healthcare providers at the facility. In this study as well, 5% of women reported that they had been physically assaulted, and 7 that they were verbally assaulted during contact as well. So even though, the systematic review showed aspect of disrespectful care, I think these results are positive to say that most healthcare providers are providing good quality care, but there's always ways that we can improve and do better. And I think respectful maternity care and really highlighting that is something that we should all be doing as part of our, professional code of conduct. So what I would like to do and what I think is important is to continue to undertake studies, longitudinal studies of quality improvement in respectful maternity care, and the treatment of women during labour and childbirth services should be undertaken. Governments, I feel that really there's a lot that has been done. It's on the global agenda. So observational studies alongside asking women as well will help to, eliminate some of the response bias. Plan additional studies in the rural hospitals and health centres. We only could undertake this in the capital city in Togo because it was undertaken during the time of COVID pandemic. And again, add in some of the other dimensions of respect for maternity care. So looking at consented care, confidential care, and non-abandonment, and see whether we can glean and gain more research with regards to that. So that's the end of my presentation, some references there. So yeah, just a brief overview of the process for the systematic review. For a lot of master's students at the minute, because there's not a lot of traveling being undertaken, systematic reviews are a really good way of undertaking research that doesn't cost anything apart from time, and it really synthesizes the evidence together to say, okay, this is the situation at the minute, what can we do to improve that? So if anybody here is motivated to do that in the spare time that I'm sure many of you don't have, please don't hesitate to get in contact with me. There's a lot that we can do together really to try and look at solutions to some of the challenges that are there. So thanks everyone for listening, and I'd welcome any questions.
Hannah, thanks so much. That was a fascinating insight into the research you've done. And I'm sure, well, I hope there'll be people willing to take you up on your offer. Though it's not an easy undertaking, is it?
No, it's not. It's not. Caitlin was excellent. She did a lot of work on that. They say to do a good systematic review takes 6 months. So yeah, it does take about 3 to 6 months to really do something well. But there's a lot of evidence that's already there that if it is brought together and synthesized, that, and once you can publish that and get that into the public domain, it will really help.
Brilliant. Well, hopefully you'll be inundated with budding volunteers.
Yeah.
Please, people that are on the call, please fire in your questions. Has anybody got anything they'd like to ask Hannah? While you're getting warmed up, then I'll take the opportunity to ask a quick question, if I may. So, I think you've really clearly illustrated the problems with respectful care and the lack of it. I wonder if you could explain a bit more about why you think there's a lack of respectful care, because I suppose understanding that will help perhaps tackle it. Because I mean, we're both, you know, you're as a healthcare professional yourself, it's almost unimaginable to think that people would go to work with the thought that they would go and provide disrespectful care. So why do you think that is?
From what I've seen, you know, from my time working in different settings, and also from the evidence, a lot of it is to do with overwork. You know, so if you're going to work, you may go in the morning with a good attitude, and you provide that first woman who comes with the great care. But as the day goes on, you're seeing a high volume. Some midwives in these settings will see 90 women at an antenatal clinic. So they're providing all types of care to them. You know, they're doing the blood pressure, everything. And you just think towards the end of the day, how can you then begin to explain everything in the same way to that woman? How can you give her the same quality and type of care that you give women before? Definitely in birth settings in the labour ward, I have seen it, unfortunately, that, you know, women are told to keep their legs shut, be quiet. You may have 5 women in one labour room without any curtains between them, so the noise does get overwhelming as well. So I think the environment as well, you're only able to provide the care that your environment enables you. You can't provide privacy or confidentiality if you don't have, you know, rooms where you can close the door or curtains that you can pull around whenever someone is in labour. And I think, again, you know, motivation, attitude, I have seen, and I'm sure colleagues here will know that often people are not paid for months on end. If I wasn't getting paid to do my job, I don't think I would really turn up with a good attitude to work, you know, and be able to do that a lot of the time. I think as well, the way that women are valued in certain societies, that will impact on the value that is placed upon, you know, them, the way they're spoken to, the way that decisions are made as well, that will have an impact. So I really think it has a lot to do with a women's status in society. In our setting here in the UK, there's laws in place. Women are able to advocate for themselves. There's users. There's lots of ways that they can raise grievances or complaints if they feel that the care they receive is not there. That has been established over many years. In some settings, that's not the case. You know, you don't have that voice. You're not able to advocate for better care. So I think it's multifactorial. I don't think anybody goes to work to provide poor care, but unfortunately, due to overwork, a poor environment, lack of motivation, then all of that really impacts on the care that women receive.
Thank you. Ewan, you've got a question.
Hello. I was just wondering the things that I think you pulled out as almost the predictors of the bad, you know, negative outcomes in your study seem to mostly be related to sort of socioeconomic status, you know, HIV status and age, younger women having worse experiences. Do you think there's a way to quantitatively, you know, predict whether it is all poverty that is driving these outcomes, or whether there is something else going on that is independent of that?
Yeah, so there is evidence out there that would suggest as well, from a quantitative research background, that definitely women who are from lower socioeconomic backgrounds will not attend for antenatal care. It's, as John said before, gaining access. You have to travel there. You may need to pay whenever you get there. That's a barrier already. For younger women, education. Do they know the benefit of it, the reason for going there? And also for HIV positive women, access to care. They won't go. So there are studies there, Ian, already to show that these are women that need specific interventions, and there is work that is ongoing with the Liverpool School of Tropical Medicine. They're doing some work in Zimbabwe. A professor there is working with women who are HIV positive and sex workers as well beforehand, to really try to integrate them into the healthcare services, to ensure whenever they get pregnant, there's already an established relationship there. They know where to go to seek care. So I think our interventions need to be catered towards some of these higher risk groups, and to ensure that, yeah, you know, adolescents, should they really be going to a different clinic? In our setting here in the UK, you know, you will have adolescent clinics where midwives will specialise for teenage pregnancies. You'll have clinics for women who are non-English speaking as their first language as well. So I think all of our interventions should be linked into that, and it would be good to do more research in those areas. But some quantitative research has already been done in that area, and I could send links onto that if that would be helpful.
Yeah, that'd be really helpful. And if you could post them onto the chat, then that might be available on when this is published on YouTube. That'd be brilliant. Thanks.
No worries.
Could I ask another question, please?
Please do.
So what I'm thinking about, maybe the interviews now and the qualitative work in particular, what were the methodological challenges and possibly ethical challenge that you faced, and how did you overcome those?
Yeah, so within all the studies that we looked at for the systematic review, there's obviously limitations associated with a place of data collection, type of data collection. Whenever I think about my own qualitative study that I'm undertaking at the minute, we interviewed healthcare providers. Now, if you're asking healthcare providers in their healthcare facility questions about what are the challenges you face during your day-to-day work, what difficulties do you have, there's going to always be a bias there. You know, you're in your place of work if your manager's there as part of the focus group discussion. So you need to put specific things there to limit that, you know, bias or recall. So, you know, making sure that confidentiality happens. Again, we tried whenever, and I think a lot of the studies that we looked at, they tried as well to interview women in their homes, ensure confidentiality was maintained throughout. Ensure that you're not reporting on, you know, any identifiable demographics of women, so that, you know, facilities or other people will not know who that is. And recall, I think it's really important to do interviews as soon as possible after the event has occurred, so you're not having, you know, any recall bias. If it's a lot of DHSS surveys, so health surveys that are undertaken in countries are undertaken maybe 2 years, 3 years afterwards. So if we're going to get high quality evidence, it needs to be taken as soon as possible after the event. And I think, you know, questionnaires is one way to collect data, but this face-to-face interviews with someone who's independent of the healthcare facility, someone who the woman hasn't met before, but trusts, and they understand the purpose of the research, why they're doing it. And I think an essential part of any research is ensuring that that's fed back to the women or fed back to the people who are undertaking the research, because then they'll realize, okay, my words have got power, someone has actually listened to me, and this is what they've done about it as well. So it's important that we look at the setting where we're undertaking the research, and we really try and limit any bias with regards to research participants, women, and where we undertake that.
So how did you then feed back the research to the participants in this study?
So for the systematic review, we've published it in the peer-reviewed journal. We use this work. So in the individual studies, I could look back to see exactly how they fit that back into the communities. I can only talk about what we've done for the systematic review. So for the systematic review, we have used that whenever we're doing our training to say it's not just about your setting, or we're not saying this happens here, but this is a problem and a challenge across sub-Saharan Africa. And I think that's really important for us to say it's not just one country, it's not just one place, there's challenges all over. So we have used this systematic review within our training. We've used these examples that women feedback as well for the midwives that we work with, to say, these are challenges, how would you overcome that? And also it helps them open up to say, yeah, that's something I've had a problem with, I've done that before. And we always bring in the charter and the rights that are actually, they have been brought into human rights law. So it's something that's recognized across all of the global organizations that are trying to improve maternal health. And I think it's just letting them know that actually these are things that are wrong, has been very helpful as well. And it is against, it's an abuse of human rights if you continue to do that type of care willingly or, you know, unwittingly as well. So that's what we have done specifically for that. With regards to the research for my PhD, I feed back all of that directly to the Ministry of Health. We feed it back to our master trainers, and we're actually feeding it back to the facility, each facility. So for the Respect for Maternity Care work there, we've stratified it by facility level, and we're feeding back individual results per facility. So they can say, we've done really well here, this is something we can do to improve. So some of those facilities are now bringing in different measures. If they didn't measure very well with regards to privacy, they're beginning to look to see how they can improve that. That's work that's ongoing at the minute.
Oh, that's fantastic. Thanks very much.
No problem, John. Thanks for your question.
Are there any other questions from the floor? Oh, Amber's got her hand up.
Well, kind of a question, also just a comment, just interesting thinking, because we'd sort of followed on from that idea of low-hanging fruit and respectful care and stuff. I thought it was interesting, and it's something I've not really given much thought about, but when you mentioned about respectful care, it's something that doesn't cost, like physically cost, no. Isn't it? It's a change of attitude, it's a shift of culture and thinking and all of that stuff. So from a sort of government, Ministry of Health, facilities getting on board with it, if they're not having to put their hand in their pocket for it, although we would need training and all of that goes with it. So you can see how that would be appealing. I thought it was just interesting what you said about how the healthcare providers felt enabled to, they didn't have to wait for a policy to change. They didn't, this was something that they could do with quite immediate effect if they wanted. And I feel like it must be quite liberating if you're in those difficult scenarios to feel like, oh, this is actually something I can do, be more conscious of. And it is interesting thinking, even with COVID vaccines at the minute, isn't it? Like, I really have to remind myself to be like, ask them about it. Have you asked them about it in the clinic? But actually it comes with time of repeatedly doing that. And yeah, just giving a bit of autonomy, I guess, and freedom to the healthcare providers. I wonder, Hannah, from like your experiences, has it been quite well received? Like, our healthcare providers, are they like, yeah, we must do this? Are they super keen? Are they quite shocked to hear that it's even an issue? Or have you ever had anyone admit to you like, oh gosh, yeah, I really played a part in that? You know, I have been disrespectful to women.
Yes, thanks, Amber. In Togo specifically, I've traveled there a number of times and I've undertaken some research, and I've been there for the trainings as well. It's amazing to see how one of the biggest things that they said was multidisciplinary training was so important. So midwives working with doctors from the same facility or neighbouring facilities was key, because they said that had not happened before. So normally it's midwives working together on maybe one specific thing, but this was a wide ranging, you know, we looked at all obstetric problems, we looked at, you know, a variety of things, medical problems and disorders of pregnancy, postnatal, you know, complications. And for them to be working together, they really began to develop solutions based on the challenges they had in their healthcare facilities. So for instance, one of the areas they developed specifically, an area for postnatal check for the newborn, that was not something that was routinely done. That's something really simple, but they were able to do that because they were all working together. The managers at the healthcare facilities were involved as well. So they had that autonomy and they would be able to work together. With regards to respect for maternity care, whenever I was doing the qualitative work, they all said the same thing. You know, now we welcome women, you know, we sit them down, we make sure that we ask them, how are they doing? They said it was difficult. They said sometimes you say to women, how's things at home? And you regret answering the question because they're telling you so much stuff, but that doesn't cost anything. And they said that the women would go with a smile on their face, because we can see through some of this evidence, women may not understand or think the most important thing is the medication you're giving them, but it's how that is delivered, how that care is received, and they will come back again, you know. So and we've also done interviews in some facilities where they didn't receive the training and where they did receive the training, and you can see a massive difference in you know, how they've heard about the training. So, you know, we've delivered it across different regions in Togo. Some of them are like, we've heard about this training, we really want it in our facility. We can see that those facilities are performing better. And something that really that we can say has happened as a direct result of the training is that more people are attending for care in those facilities, so that more women are actually coming for care in the facilities where they have received the training, because their neighbours are saying, you need to go there, these guys have got equipment, they've been trained, and they're providing good care as well. So it's been great to see that type of response.
Yeah, brilliant. And I think, yeah, you're right. And so word of mouth is so powerful, isn't it? Especially in, you know, in those kind of settings where it very much is that, and people, those cultural assumptions of good and bad, of no, I'm not going near there because that happened to, you know, X, Y, and Z happened to my sister or my friend. And the positive effects of that as well when there is good care being provided. And I just thought it just homes in on that point, doesn't it? When you pulled out of the systematic review about the women saying that she'd rather be with the traditional birth attendant in the, you know, at home, rather than coming to the facility for skilled birth attendant being there because of how they made them feel. And that is what they care about, rather than and you know, quality of care and availability of care is all very important. It goes alongside that, but actually how a woman is made to feel is obviously very important to the women, and it's been pulled out through what Mary said and what yourself said, isn't it? That actually it's really important that we find out what women want and what is important to them, not policymakers or clinicians what we feel is important, but to let them have a voice, which is exactly the work that you guys have been doing, which is incredible.
And if you look at the WHO guidelines 2016, they're called a positive pregnancy experience. So they have highlighted that the most important thing for women is a positive experience. Now, as clinicians, for us, that's like the women as well, the babies as well. You know, there's such a variety. Okay, they're all okay. Thank God we've ticked that box. They're safely delivered. But that positive pregnancy experience is what they have decided to name it, because they recognize, okay, we might have all these things in place. We may have all the facilities, everything ready. Why aren't women coming, and why are they not coming back again? And that's where we're finding is the biggest challenge again, that contact, getting women to the facilities, getting them to birth in the facilities with skilled healthcare providers.
Kathy, do you have a question or a comment?
Yeah, thank you so much, Hannah. It was really,
Kathy, you're really muffled. I don't know whether you can adjust your mic in any way. You started off earlier in the evening very clear.
Can you hear me now?
Still quite muffled.
Oh, I'm sorry.
That's a bit better.
Tell me.
Perfect.
Okay, great. Thank you so much. My question was just to Hannah with regards to thinking about the care provided and whether midwifery students were included in the interviews, just because a lot of midwifery care is given by students when midwives are absent, and whether they were included in the facility questionnaires and interviews, and also just whether we can sort of stem that back to education, and whether there's plans to sort of bring this really onto the academic agenda for the midwifery certificate, diploma or degree level midwifery education, medical education as well. I'm sorry if I missed whether you'd already said that. I was just putting my little boy to bed, but that was my main question.
Great, Kathy, thanks so much for that. So we didn't actually involve midwifery students in the workshop or train them, but nearly every single person who was interviewed as to what did you think about the training, what do you think we should do, they said it needs to be pre-service. So they said you need to deliver this in medical colleges, you need to deliver it for midwifery students, every single one, because there's such a difference between pre-service and in-service training. Now, a lot of what we do focuses on in-service. So for people who already have qualified, what can we do to upskill them? Because, you know, that's as John had said, the lowest level fit. But now we're beginning to think, and it's really changing, we need to go back to the pre-service level. So I look back to whenever I was training, I learned from people who already work, and I learned from mentors. You knew who not to learn from and who you should learn from as well. I'm sure all of us had that experience, people who were very good, people who were not so good. So unless we can learn the way things should be done, how are you going to know that what you're saying isn't the right thing to happen? So part of what I'm doing at the minute as well is I'm working with the International Confederation of Midwives and UNFPA and developing pre-service education models for MPDSR, respectful maternity care, and emergency obstetric care, because we're saying these should be delivered before the midwives hit the floor, medical students hit the floor, and we're doing some research alongside that as well. So I totally agree with you, Kathy. I think that's the most important thing that we can do to ensure, and if you have that body of, if you have that mass of people who are coming to say, this is the way we want to practice, and actually what you're doing there isn't the best way to do it, you're going to stop that sort of pervasive culture that we sometimes find in our healthcare facilities, even where we work as well, to be able to call out and say that's not appropriate. And education for girls, I think, in school, you know, adolescents in school, to say these are type of things that you know you shouldn't be tolerating. I think we've seen that as well with a lot of social activism, the Me Too movement, a lot of things, you know, it's really getting that message across to say these are certain things that should not be tolerated no matter where you are. So that's a great aspect, Kathy, and something that you've reminded me of something I need to do tomorrow, an email to send. So thanks for that. I think it's really important that we focus on pre-service, and really that's going to make a big impact.
Thank you, and good luck with it, because I really hope it's really successful. And I think just make sure that you inform the academics about how it should be a full module, at least, you know, we're talking a full term module on respectful care. Make sure that they think it's as important as the anatomy.
I know.
Because I really believe in what you're doing there. I think
thank you.
It's like what you said, a bit like cervical cancer and people not coming for screening. If with, you know, women, if women know and word gets out in the village or the city that the local health centre, the women are given care by a kind, considerate person, even just one individual. What I found in the past working at a health centre 3 in Uganda is, you know, that one individual, people want to be cared for by them. And not only that, the students want to learn from them, like you say. And maybe there will be 5 students, you know, with that one midwife, but they will turn up to work on time when that midwife is there. And they will learn respectful care from that person.
Yeah.
So just yeah, go for it. Well,
thank you. I think it is as important. I think it is as important as so many other things as well. So yeah, thanks for that, Kathy. And I think for people here who work within obstetrics, there's a lot of discussion now around traumatic birth, isn't it? You know, this is a discourse that we're hearing as well. I think a lot of that is about the way women perceive care. It's their experience. We need to know that everybody's experience is different, but it's how we respond to that. Those debriefs afterwards, how we discuss that with women can really change that experience dramatically. Thanks, Kathy.
And also, so just one more point, you know, in your module work, I think it's so important, you know, about loss and teaching midwives and doctors about how important it is to care for bereaved patients, isn't it? And because the infrastructure for postnatal care for women who've suffered, you know, any form of loss is just not you know, it's completely absent. So there's so much to do, isn't there? And
yeah,
good luck with that. Good luck.
Thank you. Thanks.
Well done.
Thanks, Kathy. They were really interesting points. Did you interview staff from mission hospitals, Hannah? And I mean, I know you're in the process of doing your PhD. Sorry, but do you have a sense about the types of care provided by different institutions? You know, are private hospitals brilliant? Government hospitals terrible? What are your?
We've tried to stratify it by either basic emergency obstetric care or comprehensive emergency obstetric care. There were some faith-based private hospitals there as well, or, you know, private not-for-profit. They're often smaller. And we did find that, yes, that women, you would find that there was more women who attended those facilities. If they were free as well, you know, all those barriers, you would find that certain facilities, the care was free. For the comprehensive, you know, emergency obstetric care, the larger hospitals, you're finding that a lot, you're getting the same type of responses coming from them, but we are definitely stratifying it by that, and hopefully we'll have enough data to be able to do that, you know, and to bring out some significant findings. Yeah, smaller facilities in the rural setting as well, it would be great to do studies there, because you'll find that often those healthcare providers live and work in the community, so you would expect, you know, different, you know, types of relationships and how that will impact as well. But yeah, that's something that I'm undertaking at the minute, John. Thanks for reminding me of all the work I still have to do. I really appreciate that.
Sorry,
okay.
It's getting late, isn't it? Getting late. Mary, forgive me, you had a hand up.
No, I was just clapping. I was just saying well done.
That was really good. I don't know, Kathy, it was really interesting hearing from you. Ewan, from you, I mean, would you spend a minute or two just explaining the work that you've done in maternity care and what things resonated with you from our 2 speakers? Would you mind doing that? Sorry to put you under pressure. Feel free to say, sling your hook.
I actually worked in one of those places that you've just mentioned, like a really remote, rural African hospital, which was a community hospital. It wasn't a mission hospital; it's a government hospital. I think that
where was that, Ewan, if you don't mind me asking?
It was in the old part, a part of South Africa called the Transkei. So it's I don't know if anyone's read about this, but when apartheid was doing their when they were in power, one of the things they did was they tried to create economic, basically islands within the country, where they basically declared areas where independent states and could therefore restrict movement of people. And obviously these areas were always sort of areas of importance to the Black population in quite a lot of areas. So where I was working is a place where near to where Nelson Mandela is, sort of grew up. Anyway, there's a lot of ramifications of doing that economically. And I think that the issues that we're all like interested in are just hugely complicated and wrapped up in things that are so far out of the scope of like what an individual healthcare provider can make an impact on. So I actually think that what you're talking about, this attitude thing, is one of the few things where, yeah, you can do something there without, as you say, like, the issue I think with my hospital, because I did obstetrics there, as lots of other things, but was burnout, chronic burnout amongst, the anaesthetists talk about this, don't they, a lot, empathy fatigue, because, yeah, you're right, everyone that I worked with, all the midwives were from the local area. They all knew people. They would often, be physically related to the women who we were, operating on or delivering in extreme circumstances. So it was, the fact that they really quite often did not convey much emotion. And I certainly have seen a lot of the negative things that you were talking about in terms of, maybe not physical abuse, but, rudeness and, really unpleasant things that people would say. And yeah, I think it probably is just chronic burnout within what is a very small midwifery community. I don't know how you can really change that without investment, is probably unfortunately the only real concrete way you could say that this could definitely be improved, is if people spent more money on remote rural healthcare, but they're not going to, unfortunately, for lots and lots of reasons. So I think one of the things that you maybe could achieve that maybe isn't 100%, part of what you've already said, but if you have an advocate coming from that community. I worked with a midwife who was absolutely amazing, and I think if she had a speech platform, she would just, she would be able to convince anyone to do anything, I think. But she was absolutely brilliant, this woman, and she more or less single-handedly ran this place, which was a decent-sized maternity unit, and it's difficult because in these kind of environments, people who are not like her tend to get through a corrupt system. A lot of these systems that we talked about are corrupt. And I don't know how you get around all that. It's almost engineered to be an incredibly difficult problem. You couldn't really write a more difficult problem to solve. But yeah, I think the attitudes, and how you could improve people's, but yeah, again, it's just hard, but yeah.
Ewan, thanks so much for sharing that experience. And I think it's a great note to end on, your talk of inspirational people, because Hannah, Mary, I think you've been a tremendous inspiration tonight. So thank you for inspiring us all. hopefully you'll be encouraging the next generation of researchers and just a general interest in the importance of global women's health. It's a vital aspect of GASOC. It's not just about surgery, it's about the whole multidisciplinary team working together, and it's a vital part of surgery, but of course so much more as well. I think maybe we should think about drawing things to a close, but thanks for giving it your time, and I hope you haven't been well, Hannah, I hope I haven't
no, don't worry, no, it's good.
Much.
It's motivational, John, it's motivational.
Oh, right, well, you're too kind,
Thanks everyone, thanks for the invite. Yeah, great to get together to meet people and see what else is going on there, so thank you.
And thank you everybody for the questions, and those of you who've joined us. Keep an eye out on our Twitter, on our email list if you're not yet part of that, for other events we'll be doing and other journal clubs that are coming up in the next few months. And as I said, you'll probably get an email with a feedback form, and there'll be certificates and stuff coming your way if you're able to complete that for us. So yeah, thanks again. Have a lovely evening. And Hannah, Mary, yeah, we really appreciate you joining us.
You're so welcome. Thanks again for the invitation. Thank you for everyone who turned up tonight. Take care.
Thanks everyone. Take care. Bye.